So it is my pleasure to welcome Peter to begin the debate for 15 minutes.
Thank you very much for that introduction, Jennifer, and thank you, Ben and Lindy, for organising this event, and all of the others who are involved in it. Jocelyn, I know, was involved in it. So it is exciting to have a conference this international here in Australia. And it's also exciting for me to start it off with a debate with Charlie. As Jennifer said, we've debated before, but it's always been a worthwhile experience, and I think it shows the possibility of having a sensible, rational kind of debate across people whose fundamental views are clearly quite different, the bases of our views. But it's possible to do that without resorting to caricature or travesty of the views of the person that you're disagreeing with. And that, I think, is one of the things that philosophy ought to stand up for. It's not just a matter of my side or your side, it's a matter of trying to get clearer about the arguments and the truth. So, because we're talking about questions about euthanasia, which are, and physician-assisted suicide, which are questions about, at least in the case of euthanasia, questions about killing, I think if you want to look at this philosophically, you need to begin by asking the most fundamental question: why is it normally wrong to kill another human being? And I think, a very brief answer to that would mention a number of different things. Firstly, normally the person that you kill wants to go on living. So in killing them, you're depriving them of something that they want, and you're also violating their autonomous choice to continue to live. Secondly, you are depriving them of the rest of their life. And although it may seem an optimistic assumption, I think it's reasonable to say that for most people, that means you're depriving them of good things, of things that on balance are good. We want to go on living not just for the hell of it, but because generally we think life is worthwhile. It brings us good things. It brings us all kinds of forms of happiness and enrichment and things that we value. And if somebody is killed, they lose all of that. And thirdly, there is also a kind of third-party reason, and that is people are parts of families and relationships and friendships, and when someone is killed, that's often a tragedy to the people who loved and cared for that person. So I think they're all good reasons why normally we should think that killing someone is a very seriously wrong thing to do. But now let's talk about the circumstances in which someone might request euthanasia or request physician assistance in dying. And if we think about those circumstances, then it rapidly becomes clear that it's probable that none of those reasons that I just mentioned will apply, or at least very likely that two of them won't apply and the other one will be somewhat mitigated in its force. So firstly, as I said, the first reason is if you kill someone, they want to go on living, you're violating their autonomy. But we're talking about voluntary euthanasia or physician assistance on request in dying. So now, in helping someone to die, in killing them if they request voluntary euthanasia, you're actually responding to what they want. You're respecting their autonomy. You're not violating it at all. So that reason against killing goes in the opposite direction in this case, where it is what the person wants, what the person autonomously requests. The second reason also generally won't apply here, because people who believe that the rest of their life has a balance, a positive balance, that the good things outweigh the bad things, are not going to request voluntary euthanasia or physician assistance in dying. They are making that request because the quality of their life has fallen to a point that is not acceptable to them. The negatives outweigh the positives. And they don't foresee that changing. And in fact, where we have legislation for this effect, the legislation often requires that they have thought about this carefully, that a second physician has been consulted to confirm the prognosis, and so on. So you can have a high degree of certainty that your life is not going to have anymore that positive balance that, fortunately, is the case for most of us during our lives. So those two reasons, which are the two, I think, central reasons relating directly to the person who is killed, to the interest of the person who is killed, do not apply. Now, it may, of course, be true that the family and friends of the person who requests voluntary euthanasia or assistance in dying still love that person and will still grieve when that person dies. But if they do love that person, they will also respect that this is what the person they love wants. And they will not want that person to suffer against his or her will. And they will want that person's autonomy to be respected. And insofar as they will grieve because that person is no longer with them, at least in the cases where we're talking about somebody who has a terminal illness, which is the great majority of cases in which one would envisage voluntary euthanasia or physician assistance in dying, then they're going to be grieving, sadly, anyway, before very long. So I don't think that third reason really applies in the cases that we're considering either. So I think we have to think about it in that rather fundamental way. We have to think about what is it that normally makes killing wrong, and are there circumstances in which these don't apply? And if so, then we don't have the kind of prima facie reason for thinking that it is wrong to kill someone. Now, all of that, in a way, seems fairly obvious. So you might say, well, why is it that it's still the case that in most of the world we do not have either physician-assisted suicide or voluntary euthanasia accepted in law and therefore able to be openly practiced? And one argument that has been quite powerful, I think, in opposing proposals for legislation is the argument that although you might have some exceptions where in fact it would not be intrinsically a bad thing if someone got assistance in dying, nevertheless you're not going to be able to confine the cases of killing to just those cases. Once you open the door a crack, once you put in the thin end of the wedge, once the camel puts its nose in the tent, you're not going to be able to stop the camel getting in or the wedge driving forward, or to use the other metaphor that's often invoked, sliding further down the slippery slope. And those arguments will be very familiar if you've been thinking about this area. And they tell us that killing is going to widen to people who don't request it, and perhaps it's going to require widen to people who the community thinks are a burden in one way or another, and inevitably at some point the Nazis and the Holocaust get brought up into the argument. Now, when I started doing bioethics, thinking about these issues in the 1970s, I didn't think that argument was plausible, but I also didn't really have clear evidence with which to refute it, because at that time we had no jurisdiction in which either voluntary euthanasia or physician assistance in dying was openly practiced, and which we had evidence of what was happening. But fortunately, that has subsequently changed, and we now have quite a lot of experience and a lot of evidence. Although, as I said a moment ago, not from the majority of jurisdictions, but we have had the open practice of voluntary euthanasia in the Netherlands since around 1990, following some court decisions, and we've had the full legalisation of it, I think 2001, if I remember rightly, anyway, around that time, so more than a decade. We subsequently had the legalisation a similar way in Belgium, which, not coincidentally, of course, is a neighbouring country to the Netherlands, and one where the majority of inhabitants speak Dutch and so can watch Dutch television or read Dutch newspapers, and are therefore in a better position than any other country in the world to be well informed about what's happening in the Netherlands. Also in Luxembourg, another neighbouring country. So we have 3 countries where that's been fully legalised, and now we have a number of states of the United States where you can practice physician assistance in dying. A doctor can write someone a lethal prescription on request. And that's Oregon, where it's been 1998, I think, so something like 16 years. Then Washington, again a neighbouring state, we get the same phenomenon. And Montana, as a result of a court decision, and now more recently in Vermont, where the practice is just starting. So we have good studies of these jurisdictions, particularly in the Netherlands, where we've had long-term studies going back to around 1990, and also we have a good set of figures, for example, published by the state of Oregon. And I think these do clearly refute the slippery slope argument. There just isn't any serious evidence of this happening. If you look at the Netherlands, in the first study, which was before voluntary euthanasia had been fully legalised but was being openly practiced as a result of the court decisions, we found that about 1.7% of deaths were the result of voluntary euthanasia. Now, more recent studies, so 20 years later after full legalisation, it's got up to about 3%, about 1 death in 33. So it's not a very dramatic increase over that period of time, and it's more or less what you might expect with greater discussion and greater knowledge of the situation. If you look at Oregon, you find, firstly, a much lower rate of use of physician assistance in dying. Only about 1 in 400 deaths in Oregon is a result of the use of that legislation. And although there's been a small increase, it's a very slight increase. I think the most recent figure was 77 deaths per year in the last year, and that had risen from 30 or 40 when the legislation first came in, but it's still a very low figure. An interesting figure, incidentally, from Oregon is that the number of prescriptions written under the legislation is significantly higher than the number of deaths. It was around 125 in the year in which 77 used it. So clearly, people like to have the prescription. They like to be in control. They like to know that they can end their life if things get bad. And the fact that they do that, but they don't necessarily use it, shows, I think, that it really is an autonomous decision that they're making. And it's not like they're under some great social pressure. Now you've got the prescription, you've got to use it. It's not like that. It's still up to their choice. So I think the slippery slope argument really is refuted by the evidence. Now there's one other thing that I want to say. We're going to be discussing in this conference later on questions about withholding and withdrawing treatment and about terminal sedation. And I think it's important that these things are all quite widely practiced. They're more or less an inevitable part of modern medicine and the intensive care powers that we have, that in every intensive care unit you're going to have decisions to withhold or withdraw treatment, and in some cases to put patients into terminal sedation. And these are legal in pretty much every jurisdiction that practices modern medicine. Now, I think they're also clearly decisions to end life, and it would take a little longer to develop this argument in full, but I don't think there's a really significant moral difference between, on the one case, withdrawing treatment, and on the other case, ending life deliberately. That's what the highest court in Britain said in the case of Anthony Bland, who was someone who was in a persistent vegetative state and whom the doctor said could never recover. And the parents and hospital requested permission to withdraw feeding from him. Inevitably, of course, he was going to die. If you don't feed somebody, they're going to die. And the judges, some of the judges said, it may seem strange that we're authorising the withdrawal of feeding tube, but that it would not be legal to give him an injection. They said, well, that's not up for us to decide, though. All we can do is apply the law as we see it. That's up to Parliament to change. So I think the judges were right. My time is up. I have to stop at this point. But I think the judges were right that there is no really clear distinction here, and it's, if you like, a historical accident in a way, in the way law has developed, that we allow one set of decisions to end life, but we do not allow another. And I think that should be changed. Thank you.
Didn't even get to ring my bell. So I would now invite Charlie up for 15 minutes.
So Peter always puts me to shame by speaking off the cuff so well. I apologize, I'm going to use some notes. First, thanks to everyone who made this event possible, and especially to all of the delegates. I know I'm particularly looking forward to question and answer, actually more than giving these remarks. And on the outside chance that 40 minutes is not enough time to resolve all our issues, please don't hesitate to continue the conversation via email or Twitter. I really enjoy that possibility, so don't hesitate. I'd also like to thank Peter in particular for doing yet another debate with me. He must be sick of it by now. But I must say the generous way that he engages his opponents allows genuine disagreement to take place. And reaching genuine disagreement is quite a rare thing when it comes to discussion of issues like euthanasia. One specific thing I think is necessary for an actual disagreement to take place, at least in my experience, is a willingness to work hard at finding out where we agree. And believe it or not, there is a lot on these topics about which Peter and I agree. And I'd like to start there by highlighting three major areas. The first is brain death. Lots of confusion in the euthanasia debate could be unpacked, it seems to me, by distinguishing between questions about moral status and personhood from very different kinds of questions about killing, treatment, and care. Oftentimes, people aren't even talking about the same topic. Much of the debate surrounding end-of-life issues is about moral status, and particularly about the moral status of those who have damaged brains, such that they at least appear to have lost consciousness or some other similarly valuable trait. One of the most dramatic questions about moral status involves something we often imprecisely call brain death. In many cases, those we affix with this label are clearly living members of the species Homo sapiens with homeostasis, with the ability to fight off infections, with the ability to react to bodily trauma, with, among other things, an increased heart rate, and even, as we saw in two very public stories in the United States recently, the ability to gestate another life. Peter and I both agree that to describe these living members of our species as dead is a bad mistake. Indeed, we agree that the history of our shift towards doing so came mostly from a desire to transfer organs after the invention of the ventilator. Now, to be clear, Peter doesn't think these living human beings should be considered persons with a legal right to life. But many of you will be aware that Peter makes the human-person distinction consistently in other cases as well, such that many other living human beings fail to count as persons as well, those with substantial mental disability and even newborn infants. Happily, the medical professions have largely rejected Peter's view of personhood and instead insists that all living human beings count as persons with the right to life. And Peter and I agree that so-called brain-dead individuals are living human beings. First agreement. Second one is one that he actually talked about. He finished by talking about aiming at death by omission and inaction. Ending life on the basis of personhood or moral status is one thing, but ending it when there is no disagreement about moral status is a very different kind of question, as I mentioned earlier, and here too we have important agreements. For instance, let me say that I totally agree with Peter that there is no difference, morally speaking, between aiming at death by omission and aiming at it by action. Removing the G-tube of a baby or PVS patient because she has an unacceptable quality of life is aiming at death. Period, it is euthanasia. But though Peter and I agree about the logical connection, I would reason the other way and say we should never aim at the death of an innocent person, in either case, whether by action or omission. And I'll say more about why later, but I think even agreeing on the logical connection is a very important agreement. The third point of agreement I want to highlight involves giving large doses of pain medication at the end of life. This is more of an agreement about what could be done in practice rather than an agreement about the underlying moral reasoning, but it's still a very important agreement, perhaps even more important, given that it deals with actual policy. Now, Peter and I agree that, one, we can give someone racked with severe pain a very large dose of pain medication. Two, we agree that such a large dose is designed to control their pain. And three, we agree that such a large dose will likely speed their death. Now, Peter's reasoning is that he uses the death, or one can use the death of the patient as the means by which the pain is controlled. And I disagree with that. Again, I believe that we should never aim at the death of an innocent person. But I do think that if a large dose of pain medication is necessary to control one's pain, you can give that large dose, as long as one merely foresees but does not intend that death will be hastened by that dose. Some will say this kind of reasoning is intellectual game playing or cheating because you know the result will be death in both cases. But this is a strange reaction given how much we use this kind of reasoning in other situations. Suppose, for instance, a parent decides to withdraw chemotherapy from her 6-year-old daughter with end-stage liver cancer. Simply because she knows this will speed her daughter's death, it simply doesn't follow that that's no different from aiming at her death. Not at all. In fact, if the cancer were to go into remission, the parent would be overjoyed. Her aim was to reduce her daughter's pain by removing chemotherapy, and the means by this was accomplished was not killing her. Her death was foreseen, but it was not intended. This kind of reasoning, which foresees but does not aim at death, is employed thousands of times every day in ICUs all over the world. Far from cheating, it is in some ways at the heart of the West's end-of-life reasoning, and we ought to keep it that way. Speaking of keeping it that way, let's talk a little bit more about disagreement. So why should we care about not aiming at the death of an innocent person? Perhaps while it's a good rule of thumb, morally speaking, aren't there just obvious exceptions? And didn't Peter talk about some of those? I don't think so, and for two basic kinds of reasons. First, historically, we know that those exceptions are generally formed for those who don't have power in a particular culture. Those without a voice to speak up for themselves, those whose dignity we find most inconvenient. Native peoples, racial minorities, the very young, and importantly for our conference, the very old. Second, I reject the idea that persons are the kinds of beings which have reducible value such that we can kill them. In fact, part of the reason many of us have the category of person at all is precisely to say that they have irreducible value. The kind of value which cannot be calculated away and used as a mere means to some other end. Persons are ends in themselves. Furthermore, the exceptionalist rule against killing the innocent is especially important for healthcare providers. Healthcare providers are professionals. That is, they are not just another person selling resources in a marketplace. Healthcare professionals have a telos, a vocation, and it is to provide healthcare. Shocking. Describing killing as healthcare means stretching the definition of health beyond what I think a reasonable person should accept. Now, one might be doing something that one and one's patient both think is in their best interests, but I hope it goes without saying that not everything one does in another's best interests is properly described as healthcare. The view that killing someone is not healthcare is behind many of the views in my country from people who are uncomfortable with healthcare providers administering lethal injections and the death penalty. Intuitively, we know it is true. Physicians are healers, not killers. But even if we come to the conclusion that it is better for someone to die than live, calling the killing healthcare seems to me to be deeply problematic. Now, one response to my argument would be simply to reject the idea that medicine is a profession in the first place, and instead claim that a medical interaction with a patient is just another market transaction. I call this the Burger King model of medicine, where you get it your way. But I think this would be a terrible development for medicine. Part of what marks the future healthcare providers I helped train in bioethics at Fordham is that they have each of them, I see it in their eyes, has a professional vocation or calling to be healers. Once we deconstruct that concept, the market takes over and we lose any sense of the profession's integrity or that there is a profession at all. Being a healthcare provider simply becomes whatever the market says it is. Another disagreement leads nicely to a second critical point, and that is about the principle of autonomy, something that Peter mentioned very early on. Some reject the very idea that a Western pluralistic culture can come up with a common understanding of medicine or health as a profession with a telos. Thus, autonomy becomes a primary value. We let individuals make their own decisions about their health care. But there are many good reasons to question the huge role that autonomy plays and continues to play at higher levels in our bioethics discourse, in particular, and end of life in general. What happens when there is a conflict between the autonomy of the patient and the autonomy of the healthcare provider? Or between one parent and another parent deciding something about the healthcare of their child? Or between the state and a parent who wants their child's surgery to be done without blood transfusion? With these cases, I submit the appeal to autonomy is an illusion. What we need instead is a common understanding of the good, in order to, what we need is a common understanding of the good in order to work through the disagreement. But that common understanding of the good is precisely what our Western pluralistic cultures and secular bioethics have tried to avoid discussing. Peter's an important exception to that, however. And autonomy is also illusion in other kinds of cases. The right to abortion, for instance, based on autonomy is well known. But such arguments usually come from people of power and privilege. Those who do not have power and privilege rarely speak of autonomy, precisely because they know they don't have it. Those concerned about marginalized populations are speaking more and more of reproductive justice, which is an appeal to a specific understanding of the good. Something similar, I argue, can be said of autonomy as it's used at the end of life. We have an ableist and ageist culture in the developed West, mostly as a result of our values being formed by a market economy. Those who have the prospect of producing capital are valuable, while those who are net drains on capital are disvalued. Unsurprisingly, those who are sent the signals that they are net drains then feel pushed to the margins of our culture and become tired of life, not to mention how being sick and in pain impacts the rationality of one's choices. So what should our response be from someone who on the margins exercises their autonomous choice and says they want to die? My instinct as a justice-centered person is to work to change our culture to help individuals see that their value is not determined by a market. Exactly the wrong response to this problem, it seems to me, is to make it easier for marginalized populations like the old and disabled and sick and in pain, to make it easier for such populations to kill themselves, and then claim that all we are doing is letting them express their autonomous choice. I submit that their choices are structurally coerced and that justice requires we change our social structures and attitudes. Now, finally, let me make a final point related to the slippery slope. This is maybe the most important disagreement that Peter and I have. As long as autonomy is the primary value in our culture and in bioethics more generally, I think we're going to struggle with something like the slippery slope at the end of life. For given this primary value, at the end of the day, who is anyone else to put limits on what could count as a good reason to form a contract with another person to kill oneself? We live in a pluralistic culture with multiple understandings of the good. So any attempt to limit the reasons for euthanasia violates personal autonomy. All of us, I think, are moved with pity for the person racked with pain with probably only days to live. But once we start sliding down the euthanasia path, it is very difficult to stop. Who are we to say that one must be terminally ill? Who are we to say what terminally ill means? Who are we to limit the policy to unbearable suffering? Who are we to say what unbearable suffering means? In a pluralistic culture defined by personal autonomy, it is the individual who makes these calls, not the state, not the medical profession. All these judgments involve deep and complex appeals to a particular understanding of the good. And haven't our pluralistic cultures attempted to make room for various different understandings? Indeed, given the strong autonomy claims of Western democracies, it's difficult to know on what basis we would prohibit assisted suicide at all, even if one was simply tired of life. And let me just conclude by mentioning the Netherlands. We saw that Peter is skeptical of the kinds of slippery slope arguments, but the Netherlands is really the only country with a substantial history to study in this regard. And at first, as with most policies, euthanasia, with regard to euthanasia, the Dutch wanted to keep the practice narrow and have strict safeguards, like explicit consent, limited terminal illness, hopeless and unbearable suffering. Today, however, each of these safeguards has been surpassed. Explicit consent has gone through the window with the Groningen Protocol of euthanasia of newborns. Belgium recently allowed for child euthanasia. Terminal illness required? Not at all. The Daily Mail recently reported on euthanasia granted to a Dutch woman given the fact that she was losing her sight. Hopeless and unbearable suffering. Consider the recent Dutch petition to allow euthanasia for those over 70 who are tired of life. It got well over 100,000 signatures, as well as the support of the Liberal and Green parties. So it's difficult to deny the consistency of their reasoning. And let me just really conclude with one quote from Theo Boer. I'm not sure if I'm pronouncing his name right, B-O-E-R. He's a Dutch official responsible for reviewing euthanasia cases, and he recently wrote an open letter to the UK, who's arguing about these issues right now, as you may know, about his experiences as this official. He says, quote, "I used to be a supporter of the Dutch law, but now with 12 years of experience, I take a very different view. At the very least, wait for an honest and intellectually satisfying analysis of the reasons behind the increase in the numbers. Is it because the law should have had better safeguards? Or is it because the mere existence of such a law is an invitation to see assisted suicide and euthanasia as a normality instead of a last resort? Before those questions are answers, don't go there. Once the genie is out of the bottle, it is not likely ever to go back in again." Thank you.
Well, thanks to both of you. I cannot believe how good you were at keeping time, given the complexities of the arguments and how much you have to say to each other. So you now have what can only be described as a lightning round chance to respond to one another, or well, probably to respond to one another, but I'm sure you could sneak in another point. And you have about 2 or 3 minutes. And Peter.
Thank you. Thanks, Charlie. I think there are many interesting things that you've said. I think one that would be good to discuss is the question of autonomy and how far we ought to go. And I'm not sure if you're aware, but in Australia there's been quite a lot of the debate about that recently because of Dr. Philip Nitschke's assistance, or perhaps he didn't assist, but anyway, involvement in some respect with somebody who ended their life when they were not terminally ill, but depressed. There's a lot more, I think, to that case that could be discussed, but it raises questions about what should we be defending and what not. Should we be defending the idea of everybody to end their life if they've given it due reflection and thought over a long period of time? I think those are real questions. I don't think it's obvious that it's wrong to do that. It's also not obvious that it's right to do that. But I think they're questions that are worth discussing as to who ought to make that decision. And advocates of voluntary euthanasia, I think, ought to be prepared to engage in that. I mean, maybe for policy purposes, you can say, as the legislation does in Oregon and Washington, well, 2 doctors must say that you're likely to die within 6 months. But I don't really think that's necessary. And you mentioned the Netherlands. The Netherlands actually never tried to say that you have to be terminally ill. Terminally ill or unbearable suffering that could not be relieved was the criterion. And I think that's a perfectly reasonable criterion. So I don't think there's been any further slipping down the slope there. And the Groningen protocol is actually also not really evidence of that, because the numbers of cases are tiny. And in fact, in the last 10 years, I think it's been applied, at least in Groningen, from only in 2 cases. So I'm sure there are many more cases where it happens, if you like, without being so openly discussed in other countries. I don't think that's evidence of a slippery slope. But I hope there's people from the Netherlands, or certainly from Belgium perhaps, who will comment on that in discussion. The only other thing that I want to say is that I think we ought to stress that people who want to end their lives are not just necessarily in pain, where you might say, well, you can give them this large dose of narcotics or whatever that will relieve their pain and end their life. But if you look at the studies of Oregon, the most frequently mentioned reasons why people wanted to end their lives, around over 80% for each of these 3, they could tick more than one box. Loss of autonomy, decreasing ability to participate in activities that made life enjoyable, and loss of dignity. Those 3 all were considered reasons by over 80%, whereas inadequate pain control was only 23%. So, there are going to be these cases where you're not going to be able to help them with the injection, with applying the doctrine of double effect. And the question is, why shouldn't they be able to make those choices? Why aren't those good reasons when people are terminally ill for enabling them to make that decision that they don't want to live the remaining weeks or months?
Is this thing on? Okay. So Netherlands asks for either terminal or unbearable and hopeless suffering. But it seems to me the counterexample of the woman who's going blind, who is offered euthanasia, is problematic, right? Because unless you take, but this gets to one of my major points, is for most of us, I think we say, well, that's not unbearable suffering. But at the end of the day, if personal autonomy is the primary value by which we're evaluating the situation, who are we to say that, right? In a pluralistic culture that makes room for multiple understandings of the good, who are we to say that? And right now we have relative agreement in the medical community about these things, but especially as patients' rights are becoming more and more prominent, personal autonomy of the patient is becoming more and more prominent, it's hard for me to see how we put in a stopgap for the slippery slope and just not say. And the 100,000 signatures for people who are tired of life, right? At the end of the day, personal autonomy is about my choice, my body, my life, my death. If autonomy is the primary value, it's hard for me to see that we're not going to continue to go down this slope. And there's been lots written on locating autonomy in surrogates, especially for children. I don't have time to get into how I feel about that in terms of an argument, but I'm pretty skeptical of the idea we locate a child's autonomy in their parent somehow. And if we're doing things like the Groningen Protocol or child euthanasia in Belgium, I think we're fooling ourselves if we think that the primary value that's being articulated is autonomy. A parent is making a decision by some other value, it's not clear what, but often some sort of utilitarian value, judgment on pleasure over pain, prospects for life, something like that. And so there are all these reasons, I think, why if we appealed to autonomy as our primary value, we're not only going to end up with the things that we've already ended up with, but it's not clear where we put in the stopgap at all.
Well, so now it's your turn. We'll welcome your questions. I believe that there are people who are now standing with handheld mics. What Peter and Charlie have asked is that you might introduce yourself and where you're from, and that you might indicate whether it's a question for one or both of them. And what I will ask is that you try, whether that is just raising the inflection at the end of your voice, or by actually pretending that you could tack a question on the end, but as much as you can to make it a question and to keep the length down so that lots of you will have an opportunity to engage. Thanks.
Yes, my name is Luc Deliens. I'm a sociologist and end-of-life care researcher for 20 years in Belgium, leading a research team on end-of-life in Belgium. And we have done some empirical studies in Europe. What we noticed in 2001, the Euro study, that it is a reality in all countries that have been investigated in Europe. So we studied the incidence of euthanasia in Belgium, in the Netherlands, but also in Italy, also in Denmark, also in Sweden. And we noticed that it is a medical practice in all of these countries, next, of course, to all other end-of-life decisions. So that's a reality that you have to face as a society. Second issue, which I'd like to put forward, is that what we see in the Netherlands and in Belgium, if you compare the quality of these practices prior to the law and after the law, that these practices have been substantially improved from a point of view of the quality of the end-of-life care. From the point of view of the clinical way they administer the drugs, the lethal drugs, but also from a point of view of the quality of the communication between the patients and the doctors, between the patients and the nurses, between the nurses and the physicians. So there's a substantial improvement in the way euthanasia has been practiced after legalization of the law. So is it not, from an ethical point of view, an ethical desirable, or is it ethical desirable to regulate these practices instead of just leaving them unregulated in a society?
I think that's for you, Charlie.
I think that would depend on this particular society. So the Iran study, which was limited in several ways, but was limited in obvious ways in that it dealt with certain cultures. And it's not clear that every society is going to benefit from regulating this rather than trying to dissuade it. I'd grant you that some cultures, that's probably the case. I don't doubt that. But I think it's not just the quality in the sense that you are referring to it. It's the question that Theo Baer, am I pronouncing his name right? B-O-E-R, asked at the end, which is, you know, if the law is a teacher, the law has a pedagogical function in cultures. And if you legalize something, we now know, there's lots of studies on this, that it changes the culture's understanding. And instead of becoming an exceptional thing, it can become a sort of just another option, right? And so that would be the thing that I would worry about in addition to it's cleaner, it's more legal, it's more transparent, it's more upfront, less mistakes happen, et cetera. I worry about what legalizing does it from a pedagogical point of view in a culture, and then the slippery slope associated with that.
No, I think.
My name is. Does this work?
You got to hold it very close.
My name is Agnes van der Heijden. I'm from the Netherlands, and I've been involved in most of the studies that have been done in the Netherlands that Peter Singer was referring to. And well, I can say many things about what was said about these studies in both your presentations, but first of all, I would like to indeed say that having a terminal illness has never been part of the regulations of euthanasia in the Netherlands. Secondly, I think the fact that issues such as euthanasia for people who don't have diseases but are old and weary of life, euthanasia for people who are having had a diagnosis of dementia and asked for euthanasia because of that, euthanasia for children, for neonates, are all topics that are currently fiercely debated in the Netherlands, which shows that having a law about euthanasia doesn't end the debate. Of course, the law involves several limits, but these limits are obviously debated in the Netherlands. And the case you are referring to about the woman who received euthanasia because she was developing blindness, it is fiercely debated in the Netherlands whether or not that is a good thing that such a patient receives euthanasia. And I think that's in principle a good thing and a logical consequence of regulating euthanasia, that such cases are discussed and that there are now and then cases that are open for discussion and open for debate, and not the cases that are the more or less standard cases of euthanasia. And these are openly debated and discussed, and the fact that one of the members of the review committees is critical about the review system and about euthanasia, I think it's a good thing. If members would only support the system and never be critical about themselves and about the review system and committees, that would not be a good thing, I think. So I think it's a good thing that members of review committees are critical about the system and critical about themselves. I think that's what I want to add.
Yeah, well, just briefly, I agree with you, and I think these are issues that ought to be discussed. And in a way, they're being discussed in the Netherlands before they're being discussed in other countries, because you've had longer experience of being able to do this openly. So I don't have a clear sense of exactly, where you would draw the barrier, as Charlie is asking, and whether indeed it's reasonable for someone to say, without my sight, I don't think that my life would have sufficient quality or not. I mean, that's something that ought to be discussed. And the only thing I would say directly about what Charlie said is that, I think if you are going to quote one member of that review committee, we ought to look at the committee as a whole and what all of the members thought about that. And then we will have a better context into which to place Mr. Boer's remarks in context and see whether this is a kind of one view out of several views where others don't see it that way.
I think the example of the woman who's going blind being debated in the Netherlands is sort of a classic exhibit A for the kind of argument I'm trying to make. So we can have this debate as a culture around this issue, but ultimately, isn't it the case that the individual patient gets to make the call? And there's a contract made with a healthcare provider to do it. And so we can have all the debate we want about what all of us think standing outside this situation. But if autonomy is the primary value that we're using to evaluate this, it's not clear it's interesting and I think even fun to talk about. But at the end of the day, who are we to decide for this person who's going blind that they don't have hopeless and unbearable suffering?
But now, Charlie, you're taking actually a more stronger line of autonomy than I did, and I think anyone else has. I didn't say autonomy was the only relevant value. I think it's a value that we ought to consider. But maybe, in some cases, you wouldn't accept it because of the loss of other goods.
Sure. I don't know if we're allowed to go back and forth. Sure, but it's not clear, as I said, in a Western pluralistic democracy on what basis we would do that, right? And especially in contemporary secular discussions of bioethics, at least in the United States and the UK, autonomy is this sort of trump card you pull out and you say, well, we all have different understandings of good. It's not clear how we're going to resolve our differences, so personal autonomy, right? Now, you're an exception to that. I think you've tried to make an argument for a particular understanding of the good. But frustratingly, I don't think there are many others doing that kind of spade work.
Jan McGregor. My background's in palliative care, nursing and aged care from South Australia. Charlie, I'm just really curious about your repeated use of the term innocent person. What do you mean by innocent? Does your view change if the person is not innocent? What do you mean by that, please?
I mean by that I'm not a pacifist. So, just police action, just war action, I think is legitimate.
Sheila McLean from Glasgow University. I'd like to come back to the autonomy question. I mean, the future that you describe, or the society that you describe, is entirely desirable in that we don't leave people to die or to choose to die. We try and enhance their position, and that's very admirable. I don't see, first of all, how the two things are incompatible with each other. And secondly, I'm puzzled by your concept of autonomy, which seems to me to be very dependent on a selfish notion. In other words, to be autonomous is to ignore everybody else that is part of your family. And I would have thought that a truly autonomous decision is one which is, I suppose, relational in its concept. In other words, it does take account of those who love you and those who are around you. And very few people grow up without those kind of connections, without some kind of inbuilt moral sense. So I don't like the thought that you seem to equate autonomy with a purely selfish decision. And I also don't know that valuing autonomy necessarily means that we shouldn't also struggle for the kinds of ideas that you have about how we might make for a more equal future for everyone.
So that one was for me. So I don't mean to suggest that anybody who makes an autonomous decision is selfish, quite the contrary. So plenty of people would make decisions that are more relational and even other-centered. Others would make other kinds of decisions. Most people have complicated relationships with self-interest and the interests of affected others. But I don't mean to appeal to a selfish notion, but just a notion which respects individual understandings of the good. Some might have a more relational understanding of the good, an ethic of care or something like that. But others may not have that at all. They might have an egoist understanding. But if we truly have a pluralistic democracy which makes room for multiple understandings of the good, it's not clear on what basis we say, well, only the relational understanding of autonomy counts as actual autonomy. That's the only one we're going to respect. If we truly are plural, then we have plural notions of the good, and we respect each and every one of them. And in principle, I think, with regard to your first question, I think you're in principle right, that there's no reason we couldn't do both. But it's not clear that that's actually what happens. So I don't see attempts to push back against market-driven forces which cause people to evaluate their self-worth as their ability to produce or not produce capital, receiving the same kind of energy as this. Maybe I'm mistaken, maybe it's just I'm a product of my own particular country in this regard. I'd be happy to be mistaken about that, but I don't see it.
Hello. Oh, hi. It's John Quinlan speaking. I'm a doctor from Wollongong, which is not as nice as Brisbane, but it's a fairly nice place down south of here. I just saw an interview with a doctor from the Netherlands maybe 4 or 5 years ago, and he was quite a happy proponent or exponent of euthanasia. And the interview asked him what the last case was, and he said it was a woman in her 70s who was lonely. And the interviewer said, and so she was killed. And the interviewer said, why didn't you just buy her a cat to keep her company? And the doctor said, oh, that's a good idea. I wish I had thought of that before. Some of the things that you're talking about just seem to trivialise life and the ups and downs and the vicissitudes of life. And I think that's a concern for the future, because it's not going to be, life's going to lose a lot if people can just peg out at things which seem to just be part of a normal life, if that makes sense. So the question is, was that doctor's decision to assist that person in dying a reasonable decision to make?
Is that a question for either of us? Or,
Did you want both to address it?
So I don't really know enough detail about what happened before that action was taken, but on the basis of just your description, no, it was not a reasonable decision. I think that if somebody comes to you, if you're a doctor or for that matter just a friend and says, I want to die, you don't just take that as a carefully considered decision that you want to act on. I think you want to say, why is that? What's the problem? And of course, if they say, well, I've got cancer and I'm feeling terrible and the doctors tell me I've got a month to live, that's one situation. If somebody says, I'm old and lonely, that's a different situation. And I think you should then get into a conversation with that person about, are there ways of dealing with this? I mean, maybe getting a cat is one, maybe moving into an old age home where you'll be surrounded by other people who are also on their own will be a way of providing company. There's a lot of things that we do in this society, and I think any reasonable person ought to know that there are a lot of things. So that conversation could go on. Now maybe this person has various reasons why none of these are acceptable options to her, and I could imagine getting to some point, but it would only be after quite lengthy discussions and consideration of alternatives and talking to any friends or family she did have, whether they could help her, that you might finally reach the conclusion that this is a long-standing view, that she's miserable, that there is nothing else you can do to help her. And so there could then be, I think, a defensible decision to help her end her life. But it would only be after the outcome of quite a lengthy process.
Charlie, I'm going to guess you're okay.
Sandra Bradley, Flinders University. I'd like to unpack this, what I consider a fallacy of equating do no harm with thou shalt not kill. I come from the nursing profession, and we provide care from birth through till death. And I'm not quite sure why there's this idea that doctors don't engage with death care.
I think that's for me. Well, just to be a little bit more precise about what I was trying to say, I don't think I ever said anything about do no harm. I think that's a different kind of argument. We can have that argument, if you like, about whether killing is harmful in se, or if there are exceptions where killing is not harmful. But the argument I made was to say that to call it an example of healthcare is deeply problematic, and actually I think just a misunderstanding of what healthcare is. Now that's not an argument for much of anything except to say we shouldn't call it as part of healthcare, and it's not clear why healthcare providers would even be the ones to do it. And I think it's an interesting example to think about. I'm not a supporter of the death penalty at all, but to think about the death penalty in the United States and why are so many people uncomfortable with healthcare providers being the ones to administer the lethal drugs in the death penalty in the United States. Well, I think it's because we have this instinct that that's not what healthcare providers ought to be doing. Is it harm? Is it not in every situation? I think there are really tough cases where I would be hard pressed to say that that's an example of harm. But I'm pretty comfortable saying that it's not an example of healthcare.
There's a gentleman up here, and then after there's a woman in the third row here.
Thank you very much. Eric Wazelenko. I'm a palliative care physician and an ethics consultant in Western Canada. I have a great respect for the place of medicine in the journey of people's lives, but I also have a great sense of humility in the place of medicine in the journey of people's lives. And I'm a bit surprised, and I'll challenge you both, and thank you for your excellent, thoughtful comments. A challenge about how we can see that there is no moral distinction between, to use a phrase, killing and letting die, or between killing and withdrawing interventions, when one might look at medicine as really merely an intervener in the journey of a person's life. And the challenge might be that if we come from a Western society that really believes that medicine has done amazing things, will continue to do amazing things, and is at the pinnacle of how we might intervene with the person. Why is that view the correct view? And can we challenge the notion that there is no distinction between killing and letting die when we view medicine in a different way?
Yeah, so certainly the view that there's no distinction can be challenged. It is challenged by a number of philosophers. It's not like there's a philosophical consensus that there's no distinction. That's a view that I would defend. And part of the issue is that there are certainly, in many circumstances, there are distinctions that you can draw. For example, about intention. So you might say that somebody who just lets somebody die doesn't have necessarily the same intention as someone who is prepared to undertake an act of killing. So to take an example from the late philosopher James Rachel's, if you want your nephew to die because you'll inherit a lot of money if he does, and you happen to see him trip over and fall face downwards in the bath, and you just decide to leave the room, leaving him to drown quietly, that's one thing, but you could argue that you didn't have the same intention that you would have to have if you actually planned to murder him. So you can draw that distinction, but Rachel's would actually have said that they're both clearly wrongful acts, despite the possible differences that you can draw in intention. There's also questions about the certainty that somebody will die. That may apply in some cases, certainly in some medical contexts. You might withdraw the respirator and to your surprise the patient continues to breathe, and maybe even in 1 in a million cases the patient goes into a miraculous remission and recovers, I suppose. So the certainty that you're bringing about death is less than if you give the patient a lethal injection. So there are differences around the distinction, but my view would be that where you have comparable intentions and comparable degrees of certainties, and that's why I mentioned withdrawing a feeding tube from a patient in a persistent vegetative state, then I don't really think you have a morally significant distinction.
I would second that, and also just drive home the point that I do think there can be distinctions between killing and letting die, then there should be. But my point was that if you're aiming at death by killing or aiming at death by some omission, the moral description of the act should be the same. So that's all I mean by that. But you can let die, problematic way of talking about it maybe, where the object of your act is not death. And I gave a couple examples of that. And there I think there would be a very important distinction to be made. But if one is aiming at death by taking out a G-tube or refusing to intubate or something like that, it's not clear to me at all why we would describe that situation differently if the death was aimed at by injecting them with an overdose of pain medication or something like that. And this is a really important point because many of my colleagues will be against euthanasia but not have the same skepticism for aiming at death by omission. And Peter's really helpful and important challenge to say, well, wait a minute, if you're against direct killing, there's killing by omission that happens every day, all the time, and not many people talk about it. And I think that's an important thing to think about.
Hi Peter, my name's Jo Dellett. I'm a nurse of 30 years and my specialty is in advanced care planning. I'm from Melbourne, Victoria. I'm very interested in the origins of even the word, the Greek euthanasia. I think it comes from euthanos, mercy killing, and that's where the concept originally came from, was that euthanasia was to provide mercy to someone with unrelieved suffering. But now I was very interested to hear in your talk today that the main reasons that that the people in Oregon gave was loss of dignity, loss of pleasurable activities and ability to participate in meaningful activities. I'm concerned about, I suppose, the loss of the art and skill of medicine in this area where you talked about people's weary of life or losing their desire to live because they're just tired of life, how that will impact, if that was to be approved, to proceed as a reason, as it already is in the Netherlands, on the practice of medicine. And I think William Osler, a great physician, once said that a good physician finds out what kind of disease a person has, but a great physician finds out what kind of person a disease has. So I'd like you to speak to, as a bioethicist of great esteem in our community, how you believe that euthanasia fits into the construct of a physician or a great physician providing beneficence, practicing non-maleficence, looking at the aspect of distributive justice and, of course, autonomy as those four great pillars of the practice of artful medicine.
Thank you very much. That's a good question, although it's a fairly challenging task to do that within the kind of time frame that we have here. But I like the quote about looking at what kind of person a disease has. And I do think that's relevant to what we're discussing because, where we're talking about competent adults, people have a vision of their life and what they think of as important in life, and perhaps also how they want their life to end, and whether they want to go through certain stages or not. And of course, people do have different views, but I certainly feel my mother had the misfortune of developing Alzheimer's disease, and after watching that, I feel that I would not want to go through that myself, but in a way she was not really suffering because somehow, it so happened that she never really had sufficient self-awareness to be able to know what was happening to her. But I would not really want my family to be caring for me in that state anymore. I mean, I felt really that my mother was physically clearly alive, but she wasn't really the person that I had known, the lively, intelligent woman who I'd known for so many years. And so I feel that at least I'm the kind of person that I would want my life, actually, my human organism, the life of that to come to an end around the time that the life of the person that I am also comes to an end. And that's going slightly beyond this sort of strictly voluntary euthanasia that we're talking about, I suppose, because it's really a matter of an advance directive and giving somebody else the power to make that judgment. But I certainly think that we have a range of people who have views about their life and what sort of person they are, and you want that to be a certain kind of a narrative. You could almost, as a bit of a stretch, see it as, see yourself as the artist creating your life as you would like it to be, and you don't want it to have that blot at the end as you see it. Now, that's a judgment that some people will make, and other people will make a quite different judgment, and that's okay, because what we're talking about is allowing people more options, which is not to say, to get back to Charlie's point, not to say absolutely every option, all they have to do is say, I want this, and then we have to give it to them. But it is to say that that's something that we ought to be thinking about in reaching these decisions. And that a good doctor who's practicing beneficence and non-maleficence and autonomy, respect for autonomy and so on, should also do.
It's always daunting when someone generously puts forward a personal story, and Peter has done that multiple times with his mother, and it's been helpful, but also challenging. With that in mind, I just want to point out two things about the story. First, it doesn't sound like we're talking about the autonomy of your mother anymore, right? Which is how we at least try almost always to talk about in secular bioethics, the autonomy of the individual patient. We try to locate the autonomy in those situations in someone else, but I think that's a deeply problematic and even somehow misguided, or it's just deeply problematic to think about your mother's autonomy existing in someone else.
Sorry, can I just cut in? In what I said just now, I wasn't making the point about what should have happened to my mother. I was making the point about what I would like to happen to me, having witnessed the experience of my mother. It was sort of informing me. So it was my decision, should I ever be in such a state.
Right. And I think that points to a challenge we have in these situations. What do we do with people who are non-decisional in terms of our principle of autonomy being the primary value? How do we work through that? And part of what happens, it seems to me, this is the second point, and then I'll just be done, we can move on, is I want to challenge the cultural understanding that we have that caring for someone in that situation, and I'm a product of this culture, right? is a burden rather than a privilege. You know, I'm a Christian theologian. I want to try to recover this idea that caring for others is a privilege. We should reject this idea that that it's a burden, and try to push back against it. But we're so formed by a culture that is consumerist in nature, I think that it's hard to imagine it as anything other than a burden. But I want to try to resist that.
Thank you both so much. My name's Michael Chapman. I'm a geriatrician and palliative care specialist. My question or comment speaks really to a number of the points that you guys were just making, both in regards to the narrative view of our life and how we want that to be, but also, I guess, this sense of care and the meaning of it. I wondered if it's possible that additional supports to people, either through healthcare or through other supports that may be available, can ameliorate their suffering, either at the end of their life or in preventing them getting to a point where they feel like death is the only option available to them. Why is that not the thing we should be doing first? That seems to be a recurrent question for me. Why shouldn't we be focusing on improving that rather than looking at euthanasia as the primary option for debate?
That's the reason why I mentioned the figures that came out of Oregon for why people wanted to end their life, because often people assume that it's physical pain that is the reason, and then you again frequently hear that there's something we can do about that. And my understanding, I appreciate there's palliative care specialists in the room and I'm not one of them, but from talking to a number of them, is it's probably true in about 95% of cases that we can do something about physical pain, but maybe not true in 100%. But whether that's correct or not, not true in 100% unless you go into terminal sedation, which I think would be a different topic, which I would argue is morally equivalent to voluntary euthanasia anyway. But the other things that were mentioned, like loss of autonomy, loss of dignity, lack of the things that the person enjoyed doing, I think it's harder to imagine how we could provide the resources to overcome those things in patients who are very seriously ill. So I think that's why there isn't really that kind of solution of saying, well, if we put more resources and more care into this, we wouldn't have to talk about ending life. It may be that there would be some cases, like the gentleman, the doctor over there who was asking about the woman who was just lonely. There would be cases like that, but I think there would still be a significant number of cases where we really just couldn't, with any resources, overcome the grounds why a person doesn't want their life to continue.
Maybe it's the idealistic ramblings of somebody in an ivory tower, but is it possible to challenge our culture's notion of autonomy, and would it count as a dignified life as being an autonomous one? I mean, I think so many people, especially those who focus more on a relational anthropology, want to say the idea that we're autonomous is just a myth anyway. Why is it that loss of autonomy also means loss of dignity? Isn't it just another kind of dependence? All of us are dependent. It's another kind of dependence. Why is this kind of dependence also come with a loss of dignity? It might be a sort of naive approach, but that's where I want to fight the battle, is trying to push back on our culture's insistence that a dignified life is an autonomous life, and to recapture the idea of relationality and dependence as being dignified.
So the two people holding the mics now are going to be the last two questions for this part of the conference. So, Chancellor.
Bill Sylvester, Director of Respecting Patient Choices. Charles, I'm not expressing a view either way regarding euthanasia, but I found that in the debate, Peter put a very cogent argument based on respect for individuals, that they know what is best for themselves. With your debate, although on the surface you seem to express support for autonomy, it seemed to come across as selective and arbitrary, and particularly I picked up on the point when you posed the question of what if someone wants to die? And then your response would be that you would tell them that their choices are structurally coerced and influenced by the market economy. And so I've formed the view that you'll respect the views of others as long as they agree with you, which comes across morally arrogant from my perspective. And I'd just like to see what your response is.
That's quite a challenge. So can I ask you a quick question of clarification? Would you draw the line anywhere? Or would you just say anyone can autonomously choose to end their life in a contract with a healthcare provider? Because if you draw the line somewhere, you're exactly like me, right? You say you can do it in some cases, you can't do it in other cases. I respect your autonomy in some cases, I reject it in other cases. So for instance, the folks that put together the ballot initiative in the Netherlands for people over 70 who are tired of life, yay, nay?
I think he's asking you.
Sorry, I thought you were putting a rhetorical question.
No. I think he's hoping to get some traction from you so that he can see where your question's coming from.
Yeah, I'm not saying that I can draw a particular line on I'm not sure if I can draw a line, but I still hold strongly for the fact that it's not appropriate for us as a society or for any particular individual that holds control to be telling someone whether they are suffering, whether it be suffering emotionally and suffering physically. The case that was put of the woman who has reached a point where, as Peter pointed out, they no longer derive the pleasures from life because they've gone blind. Now, you might say there are many people who are blind and very happy, but for that particular person, that's not the case. And who are you or I to tell that person how to live her life?
So fair enough. So your view is Peter Singer's worst nightmare, right? Because Peter wants to say the slippery slope doesn't exist. We can put safeguards in. We can have reasonable discussion about what's acceptable and what's not. And your point of view seems to be, well, that's just not true. We don't have a way of telling somebody who says, well, I'm going blind, that's hopeless and unbearable suffering, allow me to contract with a healthcare provider to get euthanasia. Your view, at least as I think you just expressed it, is we can't do that as a culture. So that is a slope going like this, right? That's not a slippery slope, that's a free fall.
I'm not making an argument for the practical aspects of euthanasia. I see it's very difficult, and I'm not proposing that. I'm just challenging you on the argument that you put forward that you're in a better position to judge the value of someone's life than they are to judge the value of their own life.
Yeah.
And I think your hope was to prove that you're both at least morally arrogant, if you are. That was your hope? Misery loves company in that way?
I'm arrogant enough to assume that we can change a culture such that people who are going blind won't feel like that they're pushed to the margins and need euthanasia.
Great. Our last question for this evening.
Yes, my name is Catherine Nicol, and I'm a PhD candidate at the University of Adelaide Law School, but I did my JD in the US. My question is to Professor Charles about if I understood your argument correctly, that because we live in a pluralistic society that's market-driven, that there truly isn't autonomy, sort of like Catherine McKinnon's argument in Radical Feminism that all sex is rape because women can't truly consent because they're underprivileged or not really have the same rights as men. So what I'm trying to understand is if that's the case, that we have market forces that create the inability to have autonomy, then your position is we shouldn't have any assisted suicide or voluntary euthanasia, and we're going to take that right away completely and make it illegal. And then aren't you taking away everybody's autonomy?
We might be able over drinks to have a longer discussion about Catherine McKinnon and autonomy and sex and rape. I'm not going to touch that one, but I do think it's pretty obvious to anyone that looks at our culture that's social. There's no view from nowhere. There's no one making a free choice standing up in some Rawlsian first perspective. We're all born into a situation that has a social structure that coerces us in any number of ways. And so when we think about what autonomy means, what we really mean is a choice that's not maybe coerced in a direct sense, like physically coerced, but still coerced by a number of social structures and forces. And so if autonomy means, you know, this Rawlsian first principle view from above, then I don't think anyone has that. But if it means something like authentic freedom for flourishing within a coherent understanding of the good, then I think there is something like that. But that would take a coherent understanding of the good, which a pluralistic democracy sort of tries to skate around by saying we all have individual choices, and we all have individual understandings of the good, and we all have autonomous choices to choose them, supposedly. So, I don't think there's a right to euthanasia. I mean, it's not surprising after these remarks.
So thank you both. I did promise that you would each have 2 minutes to offer us some concluding comments to carry us onto the kidney lawn. That's for real? Okay. Onto the kidney lawn, appropriate in a healthcare context, and to carry on this conversation over wine and cheese. But I'll invite you to start, Peter.
Thank you very much. I think we've had a really good debate that has brought out some of the issues and some of the questions that people on either side of this debate have to deal with. I really wanted to respond just to one thing that Charlie said in these closing remarks. He said something about that euthanasia will be applied to those who are weak and powerless and marginalised, the very old, the ill, those in pain, and that they're not good people, they're not in a good position to make these real decisions for themselves, to think clearly. But I think it's important that the political impetus for change here is not just coming from these people who are at that stage, but it's coming from people who can anticipate that they are likely to be in that position at some later time. So I would be an example of this. I'm certainly not among the weak and marginalised and powerless members of society. And I'm not in pain, and so I'm not able to think clearly without the distraction of pain or terminal illness. But I can anticipate that I may be in such a situation, and I can ask myself, what would I want to be done to me, for me in those situations? And I know that the things that I would want done would not be legal here in Australia. So that's why I'm an advocate for law reform on this issue in Australia. And I think, although you could say, well, yes, you know, you'll get the law, but then in fact it'll be applied in ways that these people don't want. Again, I don't really see the evidence of that. I don't see the evidence that it is being applied in the countries where it exists to people who don't want it. And I think given that those people would have families and others who are observing them, if that were the case, there would be some pressure for repeal of the legislation. But if we look at those countries that have got this legislation in place, and again, the people from the Netherlands and Belgium and so on can say this better than I can, but my understanding is there's been no serious political move for repeal of the legislation. Even though there have been changes of government during the era, they've been shifted to more conservative governments, Christian Democrat coalitions, but there has not been a serious move to repeal the legislation. So I think that does suggest that it's not being applied in harmful ways to the weak and powerless.
So thanks very much. I was looking forward to the question and answer, and for good reason. I especially appreciate the challenging remarks. Peter jokes with me that he likes to present with me because normally he's the one that gets the aggressive questions. So if you'd like to continue to engage, like I said, please do so over drinks or email or Twitter or whatever. I'd love to continue the conversation. Catholics wouldn't run hospitals, right, if we didn't care about healing and particularly palliative care. And that is a central concern. We need to push for palliative care. We need to get better at palliative care. And we've made huge strides. We can even get better. But in the push for the understandable push for reducing suffering where palliative care isn't working. I don't want us to lose the concept of healthcare as something that's a profession, something with a teleology, something that goes beyond what the market says it is. And I think we need to absolutely resist the temptation to let medicine get subsumed by the rest of consumer culture. Burger King version of medicine isn't the way to go. But most of all, I think we need to arrest this slouch, I'll call it a slouch, of secular bioethics towards the myth of autonomy. And instead, let's do the hard philosophical and theological work of arguing with each other about different and explicit understandings of the good and working through these things.
Well, thank you both so much, and also for not making me toll the bell for you. It is making me feel really conflicted about ending the debate, because I'd love to continue to hear you both. It's been a real privilege to get to sit close to you as you debate these important issues, and it is my job, though, to bring this to, if not a natural endpoint, at least a timely one, as we all want to move forward. But I did want to present on behalf of the conference organizers a small gift to you both for the time and the energy and the talents that you've shared with us this evening. And I hope you'll all join me, please, in thanking them both for this wonderful debate.